This presentation covers the basics about drugs given intravenously for induction of anaesthesia. The three main agents in modern use are Propofol, Thiopentane, and Ketamine. Propofol produces a rapid onset of anaesthesia, it has a short duration of action, and it produces clear-headed recovery with minimal or no hangover. Propofol has a short duration of action due to its rapid distribution to vessel-rich tissues. Clearance may be slow after prolonged diffusion as it accumulates in body fat. Propofol is metabolized in the liver and metabolites are cleared by the kidneys. Pain on injection is common with Propofol and can be minimized by using a big vein and running a drip at the same time. Propofol commonly causes hypotension, mediated principally through reduced systemic vascular resistance. It has a small effect on contractility also. Propofol produces pronounced respiratory depression and often apnea, and it causes deep suppression of airway reflexes, which is very useful to anaesthetists when they're instrumenting the airway. Finally, involuntary movement is common at induction with Propofol, seen as myoclonic jerks or sometimes frank epileptiform movement. Propofol can cause severe hypotension in some patients, notably people who are hypovolemic or have severe sepsis. The drop in blood pressure can be significant in patients who have pre-existing coronary artery disease, as it causes a related reduction in coronary artery perfusion pressure. And hypotension can be serious in patients who have pre-existing congestive cardiac failure. Most anaesthetists would avoid Propofol in patients with egg allergy because the emulsion contains egg phosphatide, and also in patients with nut allergy because there is soybean in the emulsion also. From the 1930s until the 1990s, thiopentane was the dominant intravenous anaesthetic agent. It's a barbiturate, it comes in powder form, it's diluted with water. It produces a rapid onset of anaesthesia. It also has a short duration of action, but it does have some hangover effect in contrast with Propofol, and it doesn't suppress airway reflexes as effectively, which is what gives Propofol a significant edge in modern use. Thiopentane has a short duration of action after a bolus dose due to its high volume of distribution. Its elimination half-life is prolonged, however, at 11 hours, so recovery from anaesthesia can be very slow after a prolonged infusion. It's metabolized in the liver, and renal clearance of metabolites, only about 1% of a dose of thiopentane is excreted unchanged in the urine. Adverse effects of thiopentane are cardiovascular, hypotension, again due to reduced systemic vascular resistance and contractility, although the hypotensive effect is less pronounced than with Propofol. Thiopentane also causes respiratory depression. It causes relatively poor suppression or even heightened upper airway reflexes at induction, and this can lead to laryngospasm or coughing if the airway is instrumented before anaesthesia is deepened with volatile agent. If thiopentane is inadvertently injected into tissue rather than a vein, it can cause tissue necrosis, and if it's injected intraarterially, the solution can crystallize, causing vascular occlusion and gangrene. Thiopentane can cause severe hypotension in patients with hypovolemia due to its effects on systemic vascular resistance, although perhaps less than Propofol does. Similarly, it should be used with caution in patients with sepsis or coronary artery disease or cardiac failure. With regard to hypovolemia, there's a legend that thiopentane caused more deaths of American sailors at Pearl Harbor than Japanese bombs did. It was a new first of its kind IV induction agent at the time,
and its effects on the cardiovascular system were not fully appreciated. Giving this new wonder drug to anaesthetise badly injured hypovolemic casualties was reported to have caused deadly cardiovascular collapse on many occasions. Thiopentane should also be avoided in patients with porphyria. It induces alanine synthase, causing a porphyric crisis potentially.
Ketamine is quite different from thiopentane and propofol. It's an NMDA receptor antagonist. The other two agents interfere with the function of GABA aminobutyric acid. It can be used as an analgesic in small doses, but is an anaesthetic in bigger doses. It has a rapid onset intravenously, and after a single dose, the patient will emerge after 10 or 15 minutes. And emergence is not clear-headed, be associated with confusion and hallucinations.
Ketamine is less likely to cause cardiovascular instability, so it's the agent of choice in patients who are suffering from, for instance, hemorrhagic shock or severe sepsis. It has sympathomimetic properties, so it results in a rise in systemic vascular resistance and an increase in heart rate. This helps to preserve the blood pressure in unstable patients. Ketamine produces minimal respiratory depression, and airway reflexes are maintained even when patients have obtunded consciousness. As a result, ketamine can be used as a sedative or an analgesic in fairly extreme situations. It's commonly used by medical retrieval teams in situations like extracting people from car wrecks to provide analgesia while the things are being cut away, for instance. And most famously, it was used as a sedative for the children who were rescued from deep in a Thai cave complex, and it allowed them to be extricated safely from the flooded tunnels.
Ketamine causes intracranial pressure to increase, so it should be avoided in patients with pre-existing increased intracranial pressure, such as people with head injuries. And because it's sympathomimetic, it can exacerbate hypertension, and so shouldn't be used in patients with pre-existing hypertension, including women with eclampsia or preeclampsia.